As I mentioned before, we have a talk coming up. After that is a panel discussion with all the speakers. And our next speaker will be introduced by Dr. Borchigan, who just presented, and she will moderate the session.
Can I use yours? Hello. Good to be here again. Thank you. Yeah. So it's my pleasure to introduce Dr. Basil Eldadah. Okay, great. Ooh, I didn't mess that up. Okay, so I had really pleasure. So this is really my first encounter. Or is it I only met Basil last night in our welcome reception, and I learned something maybe kind of secret. Is George here? I learned that Basil actually got MD, PhD from Georgetown Medical School at the same year, around the same year. Went to the MD, PhD program with the George, I'm sure. Anyway, so I see the connection. So it's great. Everybody's interested in consciousness if you go to the same school with George. Anyway, so Basil now is the program officer, as you learn very soon here from his talk, in the Geriatrics branch in the National Institutes of Aging. And before that, he did a clinical fellowship in NDEs, actually, in the clinical neurocardiology section with the Dr. David Goldstein. Okay, that I know Dr. Goldstein's work. I read a lot of his work, and he's a really champion of neurocardiology. Is one person who strongly believes the interaction between the brain and the heart. As you know, University of Michigan just recently established the Brain Heart Institute that I hope that neurocardiology is going to be a very strong, a new emerging field of research here in Ann Arbor. And I have to say, Dr. Goldstein is pushing for that for a long time. And I'm really glad that Basil actually did fellowship in his lab. And then now we have a lot more in common because I'm really interested in neurocardiology myself. And I think with that, instead of wasting his time, I'm going to just have Basil up here to begin to tell us all about the program that NIA-supported that is related to consciousness. Thank you, Basil.
Thank you so much. So I'm going to try this lapel mic. Please let me know if you can't hear me, and then we'll switch to plan B. Okay, thank you. All right, well, thank you. It's really a pleasure and an honor to be here. I'm really very grateful to have the opportunity to come to you and talk to you about a program that we are supporting at the National Institute on Aging. It's also just a personal interest of mine, both this program as well as near-death experience research. So I'll talk to you a little bit about that as well. I should mention just what I do. So I'm a program officer. So I don't actually do research anymore. I get to oversee and make recommendations about funding research. So that's actually the fun part of the job, because I get to, every once in a while, convince our director to set aside some funds to support new areas of research, and this was one of them. So I can tell you a little bit about the story and the journey behind this. It's been very gratifying professionally and personally. So I'll talk about paradoxical lucidity, then I'll pivot a little bit and just talk about near-death experiences as a model for consciousness research. Nothing that we're supporting yet, but perhaps sometime in the future. So I'll consider this an opportunity not only to tell you a little bit about some of the ideas I have, but maybe also to send up a trial balloon and get some temperature reading from the audience about where this might go. And then finally, I'll just talk a little bit about some of the other NIH programs that are relevant to consciousness science. So the story with paradoxical lucidity started several years ago. There were occasional reports in the press about this very strange, unique phenomenon where individuals, typically at the end of life, typically with some neurodegenerative condition like Alzheimer's disease or another form of dementia, who are minimally verbal or perhaps not verbal at all, bedridden, quite disabled, minimally interactive with their environment, all of a sudden, out of nowhere, start to speak clearly, lucidly, communicating often with family members, maybe with caregiving staff. Very, very strange, very out of character compared to their baseline status. And nearly always these episodes are transient. And then a short time later, at least that was the narrative up until that point, a short time after that, the individual would die. So this appeared in a few reports, and nobody really had a sense of what was going on or what to do with it. It was just something that was a bit of a curiosity. But it did pique our interest at the NIA, the National Institute on Aging, because we saw that this had some potential for serving as sort of like a natural experiment or a natural model to understand perhaps the nature of Alzheimer's disease and the trajectory of the clinical course of dementia. But also, at least for some of us, me, I thought that it might also be a window into consciousness research. So that's where the journey started. Just to kind of give you a little bit of background, so this is kind of the typical, stereotypical picture of Alzheimer's disease with regard to cognitive function. So in the earliest stages of disease, it's invisible. It is in the preclinical stage. There are no obvious apparent signs of cognitive impairment. One might look very similar to somebody who just has what you might call normal brain aging. And then over a period of time, well, there is under the surface molecular and cellular changes going on in the brain that manifest eventually in what is called mild cognitive impairment. So this is a state in which there are deficits in cognitive function, in memory, and or in other cognitive domains. But the individual is still able to function rather well. And then after several years, there is a progression then to dementia, and the dementia is classified as mild, moderate, or severe. Dementia is defined as when there is cognitive impairment in the setting of some interference or impairment with one of the activities of daily living. And as the dementia progresses into its most severe stages, then there tends to be complete disablement. And roughly on the order of about 7 years or so is how long this stage lasts, and the individual dies. As far as we know, this is the trajectory. It's relentless. It is not reversible. And there are very few treatments for this. Although we're working on it very hard, and there are some that are coming online now. Okay, so that was Alzheimer's disease, and that's the main disease that the NIA and others have focused on as a disease of dementia. But there are other forms of dementia as well. And this slide is just intended to illustrate that there are declines in cognitive performance over time with all of the different dementias. I'll just go through these very quickly. Let's see if you can see my pointer. No, you can't. Okay, so MMSE is the mini mental status exam. This is just a score of mental capacity. memory, language, attention, executive functioning, and visuospatial functioning are domains of cognitive function. And in the different conditions, Alzheimer's disease, vascular dementia, which is related to cerebrovascular events and strokes, and multiple infarcts that impair cognition. Lewy body dementia is a form of dementia that's associated with Parkinson's disease. And then frontotemporal dementia is another form, and there are two variants. You can see that these lines are all decreasing over time. So the point is that there is this kind of relentless decline in function with all dementias. But in addition to these general trends over time, over years, there are also cognitive fluctuations that happen on daily, weekly bases. So sometimes they're referred to as good days and bad days. It's not just this, this linear decline in function. And this has been recognized really for all the dementias. There's spontaneous alterations in cognition, in thinking, in attention, and in arousal. Lewy body dementia is one form of dementia that tends to have a lot of this. In fact, it's one of the distinguishing features when clinicians are trying to distinguish between the different dementias that a patient might present with. Someone who presents with these cognitive fluctuations, one might suspect Lewy body dementia. Over time, the waxing and waning course tends to diminish, and the cognitive function tends to decline evenly. And there are some existing measures that can get at this measuring cognitive fluctuations. However, none of these measures have really been able to capture those very spontaneous transient moments of lucidity. So what we know of this condition, at least what we did know up until a couple of years ago, was really based on just case reports in the medical literature, as well as other reports perhaps in the press and media. And this was a report from Michael Nahm, and you'll recognize the name Bruce Grayson there as well. They published this, this review and a set of case reports on what they called terminal lucidity. And they defined terminal lucidity as the unexpected return of mental clarity and memory shortly before death in patients suffering from severe psychiatric and neurological disorders. So many of the patients that they reported on had some form of dementia. There were other patients who had other non-dementing conditions like tumors, meningitis, schizophrenia, brain infections, brain abscesses. And I just want to show you a couple excerpts from these case reports that really kind of illustrate what this phenomena is all about. The first case concerned an elderly woman who suffered from the illness for 15 years and was cared for by her daughter. The woman was unresponsive for years and showed no sign of recognizing her daughter or anybody else. However, after a few minutes before she died, she started a normal conversation with her daughter, an experience for which the daughter was unprepared and which left her utterly confused. The second Alzheimer's case was remarkably similar. In this case, it was a woman's grandmother who had neither talked nor reacted to family members for a number of years until the week before she died, when she suddenly started chatting with the granddaughter, asking about the status of various family members and giving her granddaughter advice. Her granddaughter reported that it was like talking to Rip Van Winkle. So this is really stereotypical of the case reports that existed in the literature up until just a few years ago. But there's only so much that you can do with case reports. There's only so much that you can do with anecdotes, and we felt like maybe there's a little more science that we could do to get behind and understand this phenomenon. Why study it in the first place? Well, as I mentioned, there is an understanding about the cognitive and clinical trajectory of Alzheimer's disease and other related dementias. And these episodes would seem to question our understanding of that relentless cognitive decline. So understanding this phenomenon better may help us to understand the natural history of these dementias better. This research may also help to inform the kinds of conversations that clinicians have with patients and to help patients and their families understand what to expect with this journey of dementia. There may be some impact on how families and caregivers relate and behave towards people with dementia. If somebody is quite disabled, bedridden, nonverbal, and yet is able to manifest these lucid experiences, even transiently, what does that say about the person in there? And how should we care for those individuals? Perhaps this research could inform that. Understanding this notion of personhood over the course of dementia. And there are also some ethical challenges and maybe some decisional conflicts that can arise when witnessing these episodes of lucidity. Some family members may feel regret at admitting a loved one to a nursing home or in hospice, and then this event occurs, and then they start to question, did I really make the right decision? Should this person really be wherever they are? So there could be these kinds of conflicts that arise for family members. And then finally, there is, I think, some potential to understand the nature of consciousness. Maybe not so much as near-death experiences, and I'll discuss a little bit about why I think that. But I think it's still a potential window. So with that background and thinking, we hosted a workshop at the NIA. It was a small workshop. This is what we typically do when we want to develop a new scientific area. We gather experts in the field who have done research in the field or perhaps have done research in related fields. Now, in this case, all there was case reports. So there wasn't really anybody who was studying the phenomenon systematically. However, we did invite Bruce Grayson to the workshop, as well as a few other people, including George Mashur. And he was actually one of the co-chairs of this workshop. And there were two papers that came out of the workshop, just kind of getting this field on the map. And in this paper, by Mashur and colleagues, this was the definition given of what was now called paradoxical lucidity. And the reason for the name change from terminal lucidity to paradoxical lucidity was the fact that terminal lucidity implied an event that happens very close to death. And while that did seem to be the case, kind of looking back retrospectively at case reports, you couldn't really say that if you were studying individuals moving forward prospectively. And it also seemed that what was really the key core issue about this lucidity is its paradoxical nature, that it just shouldn't be happening. It was just so surprising and bewildering, and that seemed to be like a core component of this phenomenon. So in this paper, paradoxical lucidity was defined in an operating definition kind of way. An episode of unexpected, spontaneous, meaningful, and relevant communication or connectedness in a patient who is assumed to have permanently lost the capacity for coherent verbal or behavioral interaction due to a progressive and pathophysiologic dementing process. So that's a very long definition. It was a starting point. And you'll notice a couple things. First of all, it highlights kind of the unexpected and spontaneous nature of these episodes. It also is the individuals in whom this is being defined are people who are believed to have lost permanently the ability to communicate due to a dementia. And although the case reports that I cited earlier included individuals who did not have dementia, who had other conditions that had nothing to do with dementia, for somewhat strategic reasons, we decided to focus the efforts just on individuals with dementia because that was probably the population that was the largest, the most accessible, and there are various logistical reasons why it would make sense to study that population. So there are some key questions that one can ask about this phenomenon. What is it? What is this thing that we're calling paradoxical lucidity? What does it look like? How does it manifest? What are the behaviors that are associated with it? We've talked about speech, verbal output as a manifestation or a reflection of these lucid processes, but there may be other nonverbal behaviors associated with it. How often does it occur? The case reports and the newspaper articles would suggest that this is a once-in-a-blue-moon phenomenon. But we really don't know how often it occurs and how long does it last. The reports would suggest that they're quite transient, maybe a few seconds, maybe a couple words spoken, and that's the end of it. In whom does it occur? Is it only in dementia? Well, we know that it's not just dementia, but what is the range of individuals in whom this occurs? And what are the predictors? If you could predict, or if you had some sense of when it was going to happen, maybe you could be prepared for it. Maybe if you knew the likelihood of this happening, and if it were indeed a terminal event, then maybe if you started to see indicators of this, you could invite a family in to visit their loved one and perhaps have one last meaningful conversation. Is it only a terminal phenomenon? Does it only happen close to death? And how does this affect the family, the caregivers, the staff who are witnesses to this? An equally important question is, what is it not? What is it not? This is not just kind of like the day-to-day kind of cognitive fluctuations, but how do we distinguish those two? So these were a lot of the questions that we want to answer, and so as we often do, when we have a new concept that we'd like to be able to support and we can get some set-aside funding for it, we release a request for applications, and these were the two announcements that went out in 2020 soliciting research studies on this topic, lucidity in dementia. We called for some specific research studies, qualitative studies that would just help to inform our conceptual understanding and help to develop the working definition of lucidity. Studies that could lead to developing measures or instruments similar to like the near-death experience scales to measure the content or to determine when somebody is actually having a lucid experience and to put a number on it. To survey staff, caregivers, families, to get at some of the phenomenology, to some of the characteristics around this phenomenon, just get a better understanding of the description of what this phenomenon is. And then also to develop some technology to actually capture these moments in real time. It's one thing to be able to rely on individuals who observe the phenomenon, and that's very important. But it's quite another to be able to actually capture a recording of it, a video recording or at least an audio recording. And then, along with that, perhaps capture other measures of physiology, maybe activity monitors or even EEG or other assessments during those lucid episodes. Developing computational linguistic approaches that will help just put a number on that verbal output. So it's not just a description that the person who spoke to me was lucid and coherent, but you could actually quantify that in some way. And then studies to elucidate decision-making challenges and some of the ethical issues that may arise. So these were the awarded projects. You can see they went to 6 research groups at a number of universities around the country. And you can kind of divide these projects up into kind of 3 general bins. One set of projects was focusing on kind of retrospective studies and convening families and caregivers who have witnessed these episodes to try to inform some of the measure development to be able to accurately describe and measure this phenomenon. And then taking that information, developing an instrument, and then following individuals prospectively by using this instrument to get at these questions of how often does it occur and when does it occur and in relationship to death, and other characteristics. The second bin of studies was focusing on actually being able to capture these moments with audio, video recordings, and EEG. And the third bin, one of these projects, was focused on developing computational linguistic tools to help quantify the degree of verbal output. So what can I say so far? Well, it's still early days, so I wish that I could tell you definitively what this phenomenon is all about and everything that we've learned. I can't, and many of these reports are either in progress or have yet to be written. But what I can give you is at least some preliminary findings of what we've learned so far. First of all, with regard to frequency, it does seem that these lucid episodes occur far, far more frequently than what you would expect from the existing literature. And there's probably good reason for that, and we had suspicions that that was the case. This is just one of these cases of something that's just under-recognized for a variety of reasons. It's transient, you have to be there at the right moment to capture it. Oftentimes people with end-stage dementia are clinically stable and they're left for long periods of time without family or staff attending to them. So if there is a lucid moment, perhaps you wouldn't capture it. And then there's also other reasons. Sometimes when individuals have agitation with dementia, they're medicated, and those medications may mask the phenomenon or interfere with the ability to speak clearly. And there's just limited reporting channels. A lot of these episodes may take place in the home or in the nursing home, and it's not like an academic medical center where there's research staff on site to witness the episodes and then follow those up with reports that get into the medical literature. Those reporting channels just may not be there. What about the timing? So what we've learned so far is that many of these episodes are indeed transient, occurring on the order of seconds or minutes, but there are some cases that seem to last for days. And we're still trying to understand whether it's continuously for days or off and on over those days. So there's still more data to be gotten there. And then in terms of relationship to death, it does seem that many of the cases do happen within the hours or days preceding death. However, there are many cases that are months or even years before death. And in addition, there are individuals who have these episodes more than once. Some may have them multiple times. It's not just a one-and-done phenomenon. What are the manifestations of lucidity? Well, verbal output still is a key indicator. It's something that seems to be relatively easily measurable. You kind of know it when you see it, at least, and we're developing tools to quantify that output. So what is said is still a key manifestation. However, there do seem to be nonverbal behaviors associated with this phenomenon as well. Individuals, for example, who are bedridden, flat, unable to move. We've heard of cases of individuals who sit up when they start speaking. We had a case of an individual who was quite unresponsive and who reached out and touched the face of her daughter when her daughter gave her some very meaningful news. Eye contact. Some of these things, it's unclear whether they're reflections of lucidity or not, but to the family members who witness them, they're quite meaningful. But there are things that are a little more obvious, like playing a musical instrument or singing or dancing to music. Really, really unusual phenomenon. Paradoxical. How could this be? The emotional charge is really quite prevalent. These are deeply profound, deeply meaningful, moving experiences for the families and the staff who witness them. And in both positive and not so positive ways. For many people, family members who report this, they value these opportunities as an experience of having one last meaningful conversation with a loved one, and it sticks with them. It's very meaningful. It's also bittersweet because when these individuals have these lucid moments, it's a reminder of the person they used to be, and that's sometimes a little hard to deal with. We've also heard reports of, and this is mostly in caregiving staff and in certain institutions, who actually were upset, who were upset by this phenomenon because in their mind, they were taking care of an individual who maybe wasn't there. And to be reminded that, in fact, no, there is a person who's still there that I'm caring for, just kind of changes the nature of the job a bit, and it can be quite upsetting. That wasn't a universal phenomenon at all, but it was an interesting data point that came out of this. But there's also another unique aspect about this, which is this type of research has an impact on who participates. What we've heard from many of our research groups is that people want to participate in these studies. They want to talk about this. Finally, there's an opportunity where somebody's going to listen to them and not tell them that they're crazy because their loved one spoke when they had dementia. We've even heard reports of people who tried to kind of game the inclusion criteria so they could get into a study, even though actually they really should have been excluded. And we've heard, and this is, a lot of this research takes place in nursing homes. And so for those of you who do research in nursing homes, you know it's a really challenging research environment to conduct science. And many nursing home staff want to participate in these studies. So it's really unique and really quite gratifying to hear. And that surely has an impact on the type of science that will come out of this. We've also found that our groups preliminarily are able to capture both audio and video recordings. One of the concerns with this type of research is that individuals at the end of life or in end-stage dementia or vulnerable populations, who would consent to them being recorded? But in fact, not everybody, but many families are very willing to participate in this. And part of the reason is probably because it allows the families themselves to have a meaningful recording of their loved one and as a kind of a legacy. And that's something that's given back to the families who participate in this research. And then finally, something about the definition. So we just had a grantees meeting recently where some of these preliminary findings were presented. And one of the points that came out that many of the research groups seem to agree on is that this word paradoxical, it may actually not really be appropriate nor necessary anymore, because for one, paradoxical refers to the individuals who are observing this. It's not inherent in the phenomenon itself. It's our reaction to the phenomenon. So why should my impression of it have anything to do with what's going on in the individual who has dementia? But the other reason is that this seems to occur not infrequently, and it may be that in fact this really is a phenomenon in dementia. It's not some rare, unique, once in a lifetime event. It really is part of, or it may be part of, the trajectory of dementia. And so for that reason, this paradoxical qualifier is being reconsidered. Okay, well, we're here to talk about near-death experiences. So what does this have to do with near-death experiences? First of all, I'll talk about some of the differences. For one, this may be obvious, but lucid episodes are observed. The way we know them is not because the individual with dementia is telling us in so many words, but rather they're observed by family members, by staff members, by clinicians. Whereas all we know about a near-death experience comes from the individual who reported it. We have not yet found a way to objectively record a near-death experience or have some biomarker of near-death experiences. So they're just different reporting channels, and they have implications for how we do this kind of research and the data that we collect. Lucid episodes involve typically a brain that's chronically diseased, but there is no acute cerebrovascular compromise. There's no cardiac arrest. There's no there's no phenomenon, nothing acutely that's happening as far as we can tell. Individuals with dementia seem to be hemodynamically stable at the time when they have these reports, or when they have these episodes. Near-death experiences, those seem to be the opposite. Generally, a brain is relatively healthy, but there is an acute event. So again, there may be a difference in the pathophysiology underlying these two conditions. And then the impact of lucid episodes, they're significant. You know, people who witness these episodes, it's very memorable for them. But with near-death experiences, they're transformative. The reports that you hear of people who have near-death experiences, they have just a very different outlook on life. It really changes their worldview. And we heard some of the research that was presented on that. One other piece of data about the transformative nature of near-death experiences is regarding the divorce rate of people who have near-death experiences. I'm not sure if you've come across this, but there is some literature suggesting the divorce rate is actually quite high. The explanation being that people who have these near-death experiences have had such a radical change in how they see themselves and the world and their outlook that it's just their partner just can't relate to that person anymore, for whatever that's worth. So what are the similarities? Well, for one, both are paradoxical. How could it be? How could it be that a dysfunctional brain could be associated with a cognitively intact experience? We just can't wrap our minds around that. Both of these involve some kind of return. In the case of an individual with lucidity, it's a return from a what you might call, sometimes people refer to an individual with dementia as having two deaths. First, there's a death of the person, like their personhood, and then the second is the death of their body. And but in both cases, there is a return from that death, at least in the case of lucidity, at least transiently. Both probably occur far more frequently than have been reported. There's still stigma associated with both lucidity and near-death experiences, but the research that's being done is helping to reduce that stigma and make a safer, open space for people to report these phenomena. Both have significant implications for patient care, particularly for lucidity, as I mentioned. The understanding that there is a consciousness that is retained even in the late stages of dementia can have implications for how one cares for people with dementia. And similarly, for people who are undergoing resuscitation after a cardiac arrest, to have the understanding that maybe there is a consciousness that is there in some way or could return may impact on how we conduct resuscitations and the post-resuscitation course. And then both of these may represent kind of natural experiments to explore the nature of consciousness. So just to take a bit of a diversion, a relevant diversion. So why do we do science in the first place? We do science because we want to explain, to predict, and or to control something. And in order to explain, often we want to be able to demonstrate that a certain phenomenon, a gene, a cell, a function is sufficient for some outcome and or necessary for an outcome. And that's how we start to tease apart what are the individual factors that contribute to a phenomenon or an outcome, and then that allows us to describe, perhaps predict, and maybe even control the outcome. So this is no different for consciousness research. There is research on understanding sufficiency. Now, in this case, sufficiency doesn't mean one thing and one thing alone results in an outcome, consciousness, but rather that it plays a role. But necessity implies that a particular brain structure or function is necessary, is indispensable for consciousness. And I think some of the tension that Dr. Borjigin described with these two competing hypotheses about the role of brain in consciousness is really trying to understand this question: what is necessary? What is the minimal viable thing that we need in our brains for consciousness? So this is just a kind of an explanation for how you would go about doing this type of study. So the way to do it is, if you see a phenomenon, you get rid of something and you see if the phenomenon is still there. So, if I remove or diminish X and that results in the absence of Y, then I can conclude that X is necessary for Y. It's just, so this is how you would go about answering this question. And so this is what we've tried to do with these natural experiments with near-death experiences. But there are also other ways in which people have tried to take advantage of natural experiments. This is research that came out in 2010 in New England Journal. This is a landmark study showing that people who have disorders of consciousness, so these are people in minimally conscious states or people with persistent vegetative status, who were believed to be unconscious, but when placed in an appropriate experimental protocol, they were actually found to have brain activity associated with verbal commands. When in the top is the individuals were told to imagine playing tennis, and on the left and on the right they were told to navigate through streets in their neighborhood. And these the top images are patients, and the bottom images are control subjects, normal subjects. And what the researchers found was that there is actually brain activity in the places that you would expect it to be in response to these two commands, suggesting that in fact there is retained consciousness in these individuals, even though on the outside they appear to be unconscious. That's one way of getting at this question of what parts of the brain is necessary for consciousness. Of course, it's hard to make any firm conclusions about this because of the variable presentations of individuals who have traumatic or anoxic brain injuries, and for a variety of reasons. It's difficult to draw many conclusions other than to say a very important conclusion of this research is that individuals, despite severe brain abnormalities, retain consciousness. So the other possibility of testing necessity is through near-death experiences, and that's what we're talking about here. So near-death experiences could be a potential natural experiment to establish the necessity of brain functions, brain parts in consciousness. And it's predicated on this hypothesis that we have been discussing, that if brain activity is impaired after cardiac arrest, and consciousness remains, how could that be? Does that suggest that we don't need a brain for consciousness, that we should be looking elsewhere? And that's what the data would seem to suggest, right? Or at least that's what some are suggesting. And this is data from the Parnia group at NYU. This was published just this year in Resuscitation. This is a study called the AWARE-2 study, which followed individuals who had spontaneous cardiac arrest in a hospital setting and who were resuscitated. And this is just images showing their EEG recordings. I don't know if you could see this very well, but basically what they're trying to demonstrate here is that the red shows a representation of absent EEG, and the y-axis is the proportion of time in which that EEG signal is seen. And the x-axis is time. So this is time of CPR after the arrest. And so the point to be made here is simply that this data would seem to suggest that there is, in fact, increasingly absent EEG signals over time. It's not complete, but it does seem to be compromised. And some might look at this and say, well, there you have it. No EEG signal, brain isn't there, therefore it's not necessary for consciousness. We should be looking somewhere else. That's not the point I'm trying to make here in this slide. But this is an example of how one might go about doing that kind of research. So anyways, to take this line of questioning a little further, So this is the NDEC scale that Dr. Martial actually developed and published on in 2020. This was a building on, I might say an improvement over the Grayson near-death experience scale, which captured the different phenomena that Dr. Martial described earlier. And she categorized them using a factor analysis into these 5 different categories. So I just list them here to make the point that as we think about the functions that our brains are responsible for, and if we think about what a brain contributes to the experience of an NDE, maybe that could give us some indication of how brains may or may not be involved in the phenomenology of NDEs. So let me explain this a little further. So these are the domains of cognitive function presented earlier. There are 6 domains of cognitive function. I think I have, the next slide describes these a little better. There are 6 domains according to the DSM-5 classification. Now this is just one of several different ways of classifying cognitive function. There are many others, but it's useful for this exercise. There's complex attention, which is the ability to focus on multiple things at the same time, as well as the ability to ignore things in the face of competing calls for our attention. Executive function is the ability to plan and coordinate other cognitive abilities and behaviors. There's learning and memory. That's the most well-known cognitive function, but as you can see, it's just one of several. Language, so communication, both verbal language as well as written and spoken and in writing. Perceptual motor functioning, so this is the ability to interact with our environment, both our external environment and our internal environment. And so this involves both sensing the environment as well as responding to the environment. And then there's social cognition, which is how we process information in social contexts to understand other individuals' behaviors as well as their feelings and their thoughts, and to understand our own thoughts and behaviors. So going back then to these phenomena, this is my non-scientific experiment of how we might be able to map these domains of cognitive function onto the contents of a near-death experience. So again, the caveat, this is purely just my opinion. Not really much scientific methodology here, and this is only my impression of what I think an NDE might be like based on just my reading of the case reports. But what you might say is, so this sense of time perception, time just being flexible in an NDE, maybe that relates to our executive function, our planning ability and our ability to understand time and conform to time. The speeded up thoughts, that may be some reflection of our complex attention function. The unusual sensations, the out-of-body experiences, leaving the earthly world, reaching this point of no return and coming back, seeing a bright light or seeing oneself through a tunnel or a gateway, all of these are perceptions of some kind. And then there are these feelings of peacefulness or well-being, of harmony and unity, the gaining of insight and understanding, having precognition, having some understanding of things to come, and then the encounter with individuals. All of these involve maybe some aspect of our social cognition. Again, these are not perfect fits, and there may be more than one category. Then there's language. So hearing a voice. Many people with NDEs report hearing a voice or encountering somebody who talks to them in some way. And that, of course, relates to our language abilities. But I put a star here because in many cases of NDEs, the information that is communicated doesn't seem to be through language as you and I know it. It's not through like actual verbal or spoken words, but rather just kind of the understanding just kind of seems to appear in the absence of language. So I don't know, what do you do with that? Then there's the life review. The life review is really a fascinating phenomenon that many people, I think most people with NDEs would probably report. And I couldn't really find a way to categorize this neatly into one cognitive domain. It actually really seems to relate to multiple ones. Well, first it relates to memory and learning. So that seems pretty reasonable, that one is, has some review of one's past events, and so that involves some kind of memory. However, people who report this life review and near-death experiences, often they don't report it as kind of watching a movie necessarily, like the way that you and I would just watch a Netflix movie, but rather they experience it, they re-experience all those moments in their life. And more than just that, they not only re-experience what it was like for them, some even report experiencing what it was like for other people with whom they interacted in those moments in their life. So really a very complex type of situation that may involve multiple, social elements as well as perceptual elements. And then there are these other phenomena which I couldn't quite really see how they related to how we think about cognitive function. The extrasensory perception, the perception of things that we don't normally get through our five senses. I'm sure that there's a place in our brains for that. Ineffability, this inability to describe the events. There's no language for it. Our brains were designed to describe things, to be effable, I guess, if that's a word. So that didn't really seem to fit. The non-existence, the feeling of non-existence or this ego dissolution, that doesn't seem to be a brain function at all. In fact, our brains are just the opposite. We have these structures. It's believed that the default mode network, for example, is a set of structures in the brain that's intended or serves the purpose of giving us representation of self. And so to have this experience of non-self or non-existence just doesn't seem to relate to brain function. And then the sense of dying. Again, brains, I think, were wired to live. So in any case, again, very unscientific, but the idea was simply to go through this exercise, perhaps to generate some hypotheses and ask the question, how can we study this further? And where should we be looking in the brain to understand consciousness? Well, the traditional model has been, as we've been hearing, through spontaneous cardiac arrest and emergency resuscitation. That's been the traditional model of NDEs. And several publications have been described that report a series of individuals who are in the hospital or perhaps out of the hospital who have cardiac arrest, are resuscitated, and then a proportion of them will report near-death experiences. This type of research is very challenging for a variety of reasons. Number one is it just requires a large number of subjects. So this is the recruitment table, the flow in the study that I mentioned earlier. This was called the AWARE-2 study. And I just show this to make the point that they started out with 567 people who had a spontaneous cardiac arrest in the hospital. By the time they got down to people who had return of circulation, who survived, who were neurologically intact to have an interview, and who had near-death experiences, they got down to 11 people. That's 2% of the original study population. So it really requires a large number of subjects to collect enough people to capture these NDE reports. This also requires a dedicated on-call research team. Since it's unpredictable, you never know when this is going to happen, you have to have the research team at the ready so that once an individual has a cardiac arrest and the research team is called, they can go to the site and then conduct whatever assessments that they're going to study. So it's very challenging. It's difficult to instrument patients, to put EEG on them or to put other monitors on them that wouldn't be part of normal clinical care. And then there's this issue of not knowing baseline measures, not knowing what the individual was like before the event. And this is important because, as Dr. Martial mentioned, individuals who have NDEs often are found to have kind of a greater propensity for dissociative type events or absorption or high hypnotic susceptibility. And it's unclear, was that always the case, or was that something that they took on, some new characteristic after the NDE? You couldn't really assess that if you didn't know the patient beforehand. So not being able to collect baseline measures is a significant challenge. And then just the emergency setting just creates multiple confounds that may be difficult to control for, as much as research teams try to do that. So what about another model? It's one thing to for patients to arrest spontaneously, and then we respond. What if you could actually arrest patients yourself? What if we could actually cause near-death experiences in patients? And there is such a model, in fact, that could be used for this. So deep hypothermic circulatory arrest is a surgical and anesthesia technique that's used for some complex cardiovascular surgeries. The most common indication is when there is a defect in the aortic arch, the top of the aorta, to repair an aneurysm or other condition. And so that's typically, that can be done electively. It's not always an emergent situation. But there are situations where there is a dissection, a ripping of the aortic wall, and that is, of course, an emergency. So this technique is used in order to ensure that there isn't blood in the vessel. That would otherwise be a very dangerous situation. And so the technique involves cooling the patient down, quite cold, to 14 to 20 degrees Celsius. That translates to 57 to about 68 degrees Fahrenheit, plus complete cardiopulmonary arrest. So there's no circulation. So these patients are, we would define them clinically as dead. And in fact, blood is actually drained from the body during this time in order to facilitate the surgery. And why is this done? Because as Dr. Borjagan mentioned, when you cool the body, then that decreases the consumption of oxygen. And it's believed that the consumption of oxygen is associated with metabolic activity. And if there is a brain that wants to function and it doesn't have the oxygen to do it, that can result in death of brain cells. So this is done as a way of protecting the brain. And it turns out that as you drop the body temperature, for every 1 degree drop in body temperature, there's about a 6 to 7% decrease in oxygen usage in the brain. Such that, at normal body temperature, you have about 2.9 milliliters per gram per minute of oxygen utilization. At 20 degrees, you have only 0.2 milliliters, so a significant reduction. People have also studied EEG signaling during these periods, and if you get cool enough, you can have what is called electrocerebral silence, although maybe we haven't done the studies that to show for sure that in fact there is truly no EEG activity. And then there's also, so these operations can last for variable periods of time, but there may be up to 30 or more minutes during which there is complete cardiopulmonary arrest. One of the other advantages of this model is that there is routine physiologic monitoring. So there's either EEG or bispectral index as a measure of brain activity. There's also other measures, somatosensory evoked potentials. There's a measure of oxygen saturation, near-infrared spectroscopy, again, to get a measure of cerebral blood flow. So there is the ability to have some indication of whether the brain is functioning, or whether the brain, and if so, to what extent. And in addition, during this, routinely there are other neuroprotective strategies given to help protect the brain. Certain pharmacologic agents may be given, managing the acid and base in the blood, and then managing the tendency for clotting. So what's the literature on this? Well, not much, but there is a little. So there was a study that was published in 2010, a retrospective study of patients who underwent this DHCA in the Hôpital Sacré-Cœur in Montreal. And this surveys were sent out to 70 individuals who were identified as having had this operation. 33 of those surveys came back, and of those 33, 3 reported conscious mental activity. And this letter that was published reported a case of a particular individual, 31-year-old female, who was 31 weeks pregnant at the time and was found to have an ascending aortic dissection. So she immediately had an emergency cesarean, and a baby boy was successfully delivered, and then she was taken to the operating room where she underwent repair and replacement of the ascending aorta. Of note, the case indicates that she was under general anesthesia, as you might expect, and her eyes were taped shut, also, as is typically done. And the time during which there was no circulation was 15 minutes. During this period of time, the patient claims to have had an out-of-body experience during the surgery. And this is the quote from the paper. From a vantage point outside her physical body, she apparently saw a nurse passing surgical instruments to the cardiothoracic surgeon. She also perceived anesthesia and echography, I think that's the ultrasound machine, located behind her head. She reported feelings of peace and joy in seeing a bright light, and the surgeon confirmed that these descriptions during the operation. So, similar to what we've heard about the near-death experiences, this seems to be one. And so this is probably the first case report of an individual who had this type of experience during deep hypothermic circulatory arrest. Well, is there any other literature? Well, there's one other study I could find. This was a prospective study. This was a study in France. A prospective study of consecutive patients from 2018 to 2019 who presented with aortic, who underwent aortic arch surgery. Mean age was 63 years old. 21 of these cases were acute aortic dissections, and all of those were in the hypothermic group. And then there were 80 elective surgeries for aortic arch repairs. 2/3 of those were in the hypothermic group, and 1/3 of those comprised the control group. They did not undergo hypothermic circulatory arrest. Those repairs were done while brain perfusion was maintained. And then they determined whether there was a near-death experience through interviews of the patients after, in the postoperative course, during recovery, using the Grayson NDE scale. And so what this showed was that, first of all, the 30-day mortality was quite low. So in comparison to the studies done in spontaneous cardiac arrest, you have a much greater survival rate. There were some strokes, but they were also low. So what we take from this data is that it is possible to do this kind of study, and it may be a conducive population that, for the most part, survives. However, we're all wondering, what happened with the NDEs? Well, so they performed these interviews at day 4 and day 9 postoperatively, and none of the patients reported any recollection of their period of unconsciousness. There was no NDE report. So what do we make of this? Why would we still want to entertain this model for studying NDEs? Well, there are a few explanations that they gave in the study, and a couple others that we could speculate on. Well, first of all, anesthetic and analgesic agents are routinely given during these procedures, and they may very well interfere with the ability to consolidate memories. So individuals may very well have had near-death experiences, but they just don't recall them because of the drugs that were given to them during the procedure. I'll also call your attention to these numbers right here. The average temperature and the hypothermic circulatory arrest temperature. You see that the mean was about 23 to 27 degrees. Now, I told you that deep hypothermic circulatory arrest is defined as a body temperature of 14 to 20 degrees Celsius. And this is higher. That's why this is not called DHCA. This is actually called moderate hypothermic circulatory arrest. And so it may be that when the body is not cooled quite as much, perhaps that may interfere in some way with the NDE experience. Also, there are variations of this procedure where there may be cerebral perfusion that is done during the study. So there can actually be a return of cerebral perfusion, in which case the ability to say or to make any conclusion about whether there is brain activity or not is kind of moot because the circulation has returned, at least to the brain. So for these reasons, and perhaps others, one could speculate that maybe neurotransmitter release is somehow altered under hypothermic conditions, and that may mediate near-death experiences. It's hard to say. But it is, I do think that the DHC model is a potentially novel and innovative and useful model for studying NDEs in concert with models of spontaneous cardiac arrest. It may require fewer numbers of subjects because there's lower mortality and higher rates of preserved neurologic status. There's relatively greater control over the research environment. At least in the elective cases, you can predict when these surgeries are going to happen. You can have your research team mobilized in the operating room. Instrumentation is routine already, and because it's predictable, there may be opportunities for additional instrumentation of patients, if the surgical team is amenable. It does allow for baseline assessments if you know when somebody is going to go in for these elective surgeries. And again, this is just for the elective cases, not the emergent ones. Then you do have the opportunity to collect baseline measures and get some additional information about what was the person like before, so that if they report an NDE, you can attribute cause and effect. And then the one caveat is that there are these variations in the protocols and the administration of anesthetics that may impact on how useful this model is. So there's kind of a cooperation between the research needs and the clinical care that's needed in order to really make full use of this model. Okay, so finally, just to wrap up, I just want to mention that consciousness research is something that is of interest to the NIH. So I'm not just speaking to you about this because it's a personal interest. Recently, there was a workshop held at the NIH sponsored by the BRAIN Initiative, which is a government-wide initiative to advance brain science. As well as the NIH Blueprint for Neuroscience Research, that's another multi-institute research initiative, and the National Science Foundation. And this was a workshop to identify what are the research opportunities and knowledge gaps around consciousness research. This was kind of a first for us at NIH, and your very own George Mashur was one of the speakers at this conference. So you'll probably be hearing more about this. There is a summary of the workshop that is being developed right now and should be published, hopefully next year. There's also a consciousness research interest group at NIH. It's been around for a couple of years, but it's been somewhat inactive. However, we have had a few events, and you can go to this website and look at the webinars that have been held in the past. They're all archived. And our next event is on November 20 from Andrew Peterson, who is a philosopher of mind at George Mason University, and he's going to be giving an overview of the theories of consciousness. And we think it would be a nice way to kind of just set the stage for further lectures. Why is this research of interest to us? For a couple of reasons, both to those of us at the National Institute on Aging as well as the NIH as a whole. And this is where, in trying to think about, how to develop the science around this, we need a hook. Why should this be of interest? If we're going to set aside funding for this, then we have to convince various people that we should do that. So one of the reasons is, I think, pain. It's obviously a huge problem, chronic pain in particular, not very well managed, and yet it's a significant public health issue. We have a pretty good idea of the neurobiology of pain. When I stub my toe, we have a pretty good idea of the nerve impulses that travel from my toe to my brain. But what we don't quite understand is how does all of that neural activity result in me suffering? How do we bridge that explanatory gap? That's a consciousness question. And if we understood that, then maybe that could lead to better ways to treat pain. Because I mean, all of the neurobiology is important, but it doesn't matter until I suffer. and we don't know how that happens. So maybe there's a window there. Dementia as well. I've presented some preliminary findings suggesting that there is retained consciousness in dementia, even in the very, very late stages. And if we understood more about how consciousness relates to those cases, that might help us improve our care of individuals with dementia and their families. One might also say that there is research opportunities for delirium as a state of disordered consciousness. There is already some research going on with anesthesia and also disorders of consciousness at NIH. So I think that it's an exciting time, a lot of opportunities, and I want to leave you with just one other opportunity, and that regards psychedelics. So as I mentioned, the Lucidity initiative was something that we presented to our leadership. They were convinced enough to put some funding behind it. And so we were able to release a funding opportunity, and now there's some science. We now have another opportunity regarding psychedelics. For many years, this is not something that NIH was very interested in. However, just very recently, our advisory council, which is charged, among other things, with approving scientific concepts for future funding, approved a concept on safety and early efficacy studies of psychedelic-assisted therapy for chronic pain in older adults. So this was many years in the coming. We're very excited. We're not quite there yet. Now there's the caveat that this was an approved concept and it still has to translate into a funding opportunity, but we're very optimistic. And if that's the case, please be on the lookout for it sometime next year, where we'll be inviting applicants to submit their research proposals to conduct these studies. We intend to have one award, so we expect that this is really going to be kind of a consortium of institutions, and this is about all I can say about it now because it's still in concept form, but stay tuned for the details. So with that, I will thank you again very much. I also want to add my thanks to all the research participants and the individuals with NDEs who they really have suffered a lot, and it's through their suffering that we've been able to learn. So I think we really owe them an immense debt of gratitude. And thank you to everybody for the opportunity. If you have any questions, please contact me.
Hi there. Thank you for this lecture. I'm an inpatient neurohospitalist, and it's really changed my outlook on how I prognosticate ICU patients. But I had a specific question for Dr. Basil. So for patients for the lucidity piece of dementia, did you notice any variation in the subtypes of dementia that you mentioned? And also, do you see any correlates? Like we've mentioned vascular contribution for possible NDEs. Do you think there's a potential hypothesis for proteinopathies like tau or alpha-synuclein contributing to NDE experiences?
Okay, so I'll two questions there. So the first question regarding different forms of dementia related to lucidity. From what we've seen so far and what our research groups have found, there does not seem to be much of a distinction. It seems like the lucidity is a phenomenon in dementia types overall, but the numbers are kind of small, and just by the very nature, the dementia that typically presents is either Alzheimer's or mixed dementia or vascular dementia. So it's still a little bit hard to say, but it does seem that at least from what we're seeing, this may occur in all dementias. Regarding the the speculation about proteinopathies or different kind of pathologic changes in the brain related to NDEs. That's a great question. I think where there's potential is this hypothesis that if you have a hypofunctional or a pathologic brain, how is it that you have NDEs? And if you have a brain that's filled with amyloid or tau or other aberrant protein misfolding, does that result in a brain state that's sufficiently impaired for us to then conclude, well, maybe we should be looking somewhere else for consciousness? And I don't think we're quite there yet. I think we just don't understand how much of our capacity is in fact still retained despite widespread brain pathology. So I'm not sure if, I think the jury is probably still out on your second question.
Hi, thank you for the great talk. And I always consider the Alzheimer as or dementia as a loss of function, like loss of the cells, and the cases of lucidity makes me rethink dementia as a gain of malfunction rather than loss of function, so that the normal personhood was like veiled by abnormal, aberrant neuronal processes. So a little bit related with the previous question, but can I do you think this is kind of a valid understanding?
Yeah, I think it is. Actually, it's very fascinating. So some people have actually speculated that, just like with many things in science and medicine, our framework kind of changes, and we go from thinking about things in pathologic terms to thinking about things in terms of adaptive terms. Like, maybe evolution selected for this for a particular reason. Why? Is there some purpose or benefit served by it? I don't think we're at the point now where we can say, well, there's some purpose or benefit of Alzheimer's as a disease. I think it's still quite a terrible disease and impactful on individuals and families. But that said, some have speculated that when you kind of impair the brain in some way with dementia, that may unmask or create a window or an opportunity for other functions to emerge that perhaps were not there during normal cognitive processes. Again, I think it's speculation. I don't think we're anywhere near having the tools or the instruments to be able to measure that. But it is an interesting hypothesis. In fact, there's one case report that I read of an individual whose mother had dementia, and she kind of chronicled that journey with her mother. And she reports several instances of her mother kind of giving her like information and insights that she herself didn't really understand or appreciate. And she, it does suggest, for one, we clearly don't know enough about the natural history of dementia. But number two, I think maybe it's also an opportunity for a little humility to appreciate that maybe there's something else going on there that we don't understand.
Hey, thank you for that beautiful talk. I'm really interested in the idea of paradoxical lucidity, and you mentioned about the power this has for the families and loved ones. But I'm also curious, the people who experience the paradoxical lucidity, especially if it's long lasting, do they know they're experiencing it at any point? Are they aware of that? And in your experience, looking at the literature and firsthand, is that something that comes up?
Yeah, that's a great question. So you're getting at sort of like the meta-consciousness of lucidity. And this is the one of the points I was trying to make, is that most of what we understand about lucid experiences comes from reports of people observing the phenomenon. And so we're kind of seeing the phenomenon through their lens. We don't, and again, the data is quite preliminary, and it may be that we have that data or it's going to be forthcoming, but we don't have a great sense of whether individuals who are having these lucid moments are in fact aware or surprised by it. It's just, I think it's a little early and we don't have the data, but that is something that some of our research groups are actually keeping an eye on. So thank you for the question.
One more, just a quick follow-up on that one. So you mentioned an anecdote of the daughter, the mother or grandmother was providing information. Was that about the dementia state that it wasn't
No, it
about?
wasn't about the dementia state. It was about, I forget the details, but it was something about the daughter's own life and life situation.
Okay. So as you were just saying, it's still something to investigate. Just one other quick point. You're familiar with Tony Bennett and the amazing ability to sing during the condition he was. Would that be like a subset of lucidity, or is it like maybe qualitatively a different process going, that the ability that musical talent is so deeply ingrained in the brain structure that it just manifest?
Yeah, that's a great question, right? Because it's a completely different kind of cognitive ability from the language and the other things that we've been talking about. So this phenomenon of, so to answer your question, I don't know. It probably is related in some way. What we do know is it's a well-recognized phenomenon that for some people with late-stage dementia, they can respond to music in a way that they would not respond to verbal language. So yeah, there probably is a different part of the brain that's being tapped or perhaps spared in the dementing process. I wouldn't be surprised if we come to learn that in fact there is some parallels between those two, but for now I think we just don't know. Yeah.
Thank you very much again.